Hi, I am Dr. Shervin Molayem, and thank you for having me. I am really excited to give this presentation today on a topic I'm really passionate about and have been working on for a little while now. A little bit about my background. I'm a periodontist, and I've been working for the past 10 years in private practice. And I went to UCLA Dental School and did my periodontics training at USC, and I'm really excited to be here. So without further ado, I'd like to present my topic, which is on the mouth-COVID connection, IL-6 levels in periodontal disease, potential role in COVID-19 related respiratory complications. And this is an article that I co-authored with Dr. Carla Pontes, who's a periodontist as well and a PhD in South Africa. And we just had this article published in the California Dental Association Journal. It will be in the October issue. We're really excited about getting this information out. They have made it available via online digital form as well. So you can see the whole article on mouthcovid.com. Mouthcovid.com. All right. So in a nutshell, this is kind of how overall scheme looks like of the pathways where COVID and the mouth are connected. Some pathways you'll see are directly, some are indirectly related, and we're going to delve into each one of these in detail. But this is the scope and the overall map of where we're going to be heading in this presentation. I would like to ask any questions we could hold for the end, and I will be happy to answer them. So as far as the presentation, we're going to go through the introduction first, talk about how IL-6 relates to actual periodontitis in specific, and then we'll get into respiratory diseases and periodontitis, and then talk about IL-6, viral infections, and COVID, and the mechanisms, how everything ties together, and periodontal treatments in COVID-19. We'll talk about genetic testing and solutions. We need solutions. We need to talk about how to take steps and actions to move forward in a positive way. The clinical importance of this review article lies in the awareness that in general, right now, dental professionals, they can have such a huge impact on what's going on in their patient's health, overall health, especially during this pandemic, because we all know that the mouth is connected to the body through the bloodstream. That's a direct relationship, and we're going to talk about other ways why, but this is already known. So I'm just going to present some information and some data on how this is connected more specifically to COVID. So in general, with COVID, we're seeing about 80% of the people who get it, they have mild cold symptoms. They may not even know they have it. They may be asymptomatic possibly, but so nothing major is happening in about 80% of people. And these are usually the young, the people who don't have any contributing factors like diabetes or heart disease. We have 20% that we're seeing severe symptoms like respiratory problems. When we talk about severe symptoms, we're talking about respiratory, because this is a respiratory disease. This virus goes to the ACE receptors, which literally goes to the nasopharynx, down the throat, and into the lungs. 5% are life-threatening, which means they're in the ICU and they're having a machine pump their lungs and breathe for them. All of these are connected, and this downhill, the spiral, what we call, that going in a negative direction, is contributed by the cytokine storm. And in particular, this was shown and proven in a German study that we're going to talk about, which is what actually sparked my study. Really, I think that article, we're going to delve into it. It should be explained really to all of our patients, because It's so important. It's one of those articles that shows kind of life and death, how to stay alive. In dentistry, we are working in the mouth. The mouth is a transmission route. We have salivary glands, which function as reservoirs for COVID-19, which is actually a publication I'm working on right now, in particular, looking more at the reservoirs for COVID in the mouth. Saliva and how infective it could be, because you can swallow it, you can aspirate the bacteria. And also occupational health issues. So infection control, we're dealing with the mouth. We have aerosols in the air. So we have to talk about that a little bit. And also PPE and financial issues. So this is how all ties into kind of what we do. In particular, what we're seeing now is to date, according to the American Dental Association, dental offices are back. They're getting back on track. They're about at 70%, which is not so bad. I mean, these patients they're getting back into the dental offices, which is great. At about 70% capacity, hygienists have started to come back, and the offices, they're on backlog, so they're getting busy. So we're heading in a positive direction. That's according to the ADA. They had a webinar this past week, and so that's where we're at right now. Mouths are a little bit dirtier than they were before because people haven't been able to get into the dental offices. People's glass cleaning may have been, a year or two ago. We have, people that are home that have some more, bleeding, some more plaque, and so that all ties into kind of where we're at right now in the landscape. So in general, we know that periodontitis causes an increase in systemic inflammation and an increase in cytokines, increase in IL-6. This is already shown and proven with strong associations in literature. We see lowered inflammation with treatment. So we know that doing periodontal cleanings, deep cleanings, SRPs, all of that lowers inflammation in the whole body. So we're going to talk about some articles, but also it's not just periodontal disease that we're talking here. We are talking about periapical lesions. We're talking about a root canal that may have been going bad. That's been kind of asymptomatic, but for years just kind of, okay, let's push it off, let's do a retreat of the root canal. Those also have been shown to have IL-6 and direct supply to the blood. So that's another source that they've seen in research of how bacteria, how the toxins of bacteria. Remember, bacteria, we're going to talk about, have toxins that actually leak and do harm as well. They have different bacteria go in the bloodstream, that their toxins go in the bloodstream, and then the cytokines are in the bloodstream. So it's a triple whammy there. And we have such a high prevalence of people with periodontitis. About 47% of Americans that have some sort of periodontitis, whether it's mild, moderate, or severe, and especially in patients that are 65 years and older, that jumps up to 70%. So they're out there. So I mean, 70% of our patients that we see that are above 60 years old have a problem, and it's not gingivitis, we're talking about periodontitis. Gingivitis meaning you have an inflammation in the gum, it hasn't really got into the bone. Periodontitis meaning you have more of an inflammation or infection of the bone. So this is an issue. Prevalence is so high. And then we've had this limited supply of dentists in the beginning of this pandemic, now increasing. We had the shortage of hygienists that now we're seeing them come back. So we're definitely heading in a positive direction, but this is something that we need to be talking about with our patients right now because it will affect them. Now, this is from about a week ago, but we are seeing, you know, a large amount of cases as far as COVID. And this could be attributed to the amount of testing that's done. So the more testing that you have, the more cases that you're going to see. And we're also seeing more hospitalizations. Now we're seeing this curve start to dip a little bit. So we are heading in a good direction. We are seeing hospitalizations go down. This can be attributed to possibly herd immunity, where we were looking at B cells and we were looking at antibodies. Now we're looking more at T cells and cell-mediated immunity. So that's really important and that's positive news, because if we're searching for antibodies and we're looking and we're seeing someone that got COVID, their antibodies went down, well, we don't need to be so scared of reinfection, because there's also another pathway, and that's the T cells. And this might be the reason why kids aren't getting the COVID complications. And that's because they already have so many coronaviruses in their body that they've had recently. And so their body has these T cells ready. You know, they're really, you know, they're called the demolition cells. They're the T fighter cells. They're there ready to fight, because this virus, when it comes into the body, it camouflages itself in the beginning. So it secretes an enzyme which tricks the body into not seeing it in the beginning. So if you know, while the virus is starting to replicate, you already have these T cells available. I think that we're in better shape than we thought with this new news that has been coming out. And as far as the deaths, again, we've seen, this is again from about a week and a half ago or so. So we're seeing a little uptick in deaths, but it doesn't seem like it's a very sharp uptick, and starting to kind of level off. So if you look at New York and you look at London and you look at Italy, a lot of the places that were hit really hard, those places are, as far as deaths, the graphs kind of going in a downward, good direction, possibly a sign that we are seeing some herd immunity. We'll see where that goes. Now, IL-6 in relation to periodontitis. IL-6, what it does and where it's released is by so many different cells. Our body, when it gets this intruder, our soldiers, so to speak, get activated. And the first soldiers in line are the neutrophils and the macrophages. They're already there. They're already going through the bloodstream, trying to gobble up and eat things. So that's a part of our innate immune system. We already have that. The next line of defense is the T cells and the B cells and the all these other cells that come into play, which they all secrete IL-6 as well. So you have every soldier in your body releasing IL-6. Think of it like there's a war. Back in the day, there's a war, and they don't have telephones or anything to call the people who are in the city, and this is the intruder is coming. So they're sounding the alarms. IL-6 is like one of the main alarms. They sound the alarm, the next person sounds the alarm. It's a cascade of signals, and eventually it gets to everyone. And so everyone's releasing this, and when it gets released, there's also some damage. And that's why it's a pro-inflammatory cytokine. It's released by all the cells, epithelial cells. That means the cells that are just on the epithelium. Endothelial cells. That means the cells that are lining your blood vessels also release them. So that means throughout all your blood, you have these endothelial cells that get released, releasing this IL-6. So this can be really bad and add up. Now there's other signaling proteins that get released. CRP, which is C-reactive protein, and you have IL-1, IL-12. You have all these different mediators. But we're talking about with COVID, we're talking about IL-6 is the main one. Secondary would be the C-reactive protein, CRP. Those are the two ones that you'll see in a lot of people that have a lot of chronic inflammation, chronic diseases, such as arthritis, lupus, diabetes. You'll see an increase in IL-6 and CRP, autoimmune disorders as well. So we got to also talk about, there's different types of IL-6. I don't want to get too much into that, but we do have different polymorphisms or different types of these IL-6. For our purposes, there's two of the most common ones. But even more importantly than these two common ones is we have alleles genetically that we're born with that either you're a C or a G. So you can have two alleles. Either you're a GG, GC, or CC. And you can spit into a test tube, send it to the lab that, oral DNA is the one that I use. There's other labs, but oral DNA, for example, you send it to them, and then they'll send you a report, which we'll show you in the upcoming slide. And you'll see if you're a high risk, medium risk, or low risk. Now, what does that mean? It means that your body already has a susceptibility to these, the cytokines and to this inflammation, and how when IL-6 gets released, those signals and those soldiers ringing the bell, sometimes they go too crazy and out of control, and so it storms, and you have an out of control reaction. So we would know from our gene if we're high risk, medium risk, or low risk, GG, GC, or CC. And that's good for someone, for example, who is elderly. They might want to know if they are high risk, so that if they get COVID, or even for other diseases like any diabetes or lupus or any of those, but if they get COVID in particular, because we're talking about it now, they know possibly how the body will react. And there's going to be more research done on this, I'm sure. They'll probably be looking, and I urge someone listening to this to do a study on this. Find out what people's genes are of the people who are coming into the hospitals, of the people who are dying. You can do a beautiful, easy study and find out if there's any relationship between that. So that's the next phase. Now, high expressions of IL-6 have been reported also in gingival crevicular fluid, in the tissue. They've been seen in the fibroblasts. So locally, we're talking. They release something called LPS. So you have to think bacteria come in the gums through the plaque, and they release different weapons. And one of these weapons is called LPS. LPS is lipopolysaccharide. It is strong, and it can break down tissue. So that's one way how it kind of gets in, as far as the bacteria. Also, the IL-6 gets released locally and has been involved in bone destruction and preventing bone formation. So that's another way it's getting into our body, because remember, in the bone, you have a lot of blood vessels, and that's how bacteria get into our bloodstream. So if you're destroying bone and getting into the bone, then that's another pathway. That's going through the gums, the gums have blood, getting to the blood, then going into the bone has blood, and this causes a spread. Also, another weapon that they have is called the MMP. So MMP, or metalloproteinases, basically they are able to break down collagen. And when they break down collagen, and that's how they're getting into our tissue. We see a lot of that in, like, for example, those stronger bacteria like P. gingivalis and AA. They have a lot of these weapons that we're talking about. So IL-6 is in periodontitis. Again, it's the reservoirs. We have really four places where these bacteria get into. and that's in our saliva, gingival curricular fluid. We see it in people with periodontitis, it's higher. We see it in the tissue, which we talked about. But the main thing that we're going to be talking about also is the serum. Okay, serum is the part of the blood that doesn't coagulate, doesn't have any fibrinogen. So it's been shown that when this people with periodontitis, they could be ranging usually from 0.25 picograms per milliliter to all the way that they've seen it to 41. That's the normal range with people with periodontitis. So remember these numbers: 0.25 to 41. But the outlier, they've seen someone in their blood to have 216, for example, picograms per milliliter of IL-6. So that's when you draw their blood and you see, you can measure their IL-6. And we're going to talk about that as far as solutions, what patients could possibly be doing as preventive measures and diagnostic measures for this future. So this has been shown and proven. So many articles on IL-6 and periodontitis, so many. And we had to go through so many articles. That's what took so much time in putting this together, is the amount of articles that there's already been published on this, and that you have to read and see which ones the methodology is good and which one is valid, and we have to look at systematic reviews, because you can't just trust one article. You have to look at summaries, basically. Systematic review is a summary of all the articles. And if you have, for example, 4 articles that show something is positive and 8 articles that show something is negative, then you know that it skews to the negative. So you want to look at the collective measure when you're doing a systematic review, which is why I partnered up with a PhD, a periodontist, to make sure, number one, everything that we're doing is by the book. Also, the speed. We needed to get this thing out fast, ASAP, because the faster we get this out, the more lives that possibly we could save. And so let's get into, there's been basically strong evidence of IL-6 and periodontitis, which we talked about. We have the genetic studies. It's been in the tissue, and periodontal treatment, was we're going to talk about, it can decrease the amount of IL-6 expression. And also lesions. People who have periapical radiolucencies, maybe they have a root tip that's been sitting there for a little while. It doesn't bother them. Maybe they have, and they can have an issue. They can have IL-6 being released. Remember, if something is open and it's a root, you have the pulp possibly exposed. You have bacteria leaking into the bloodstream. If something is near the sinus, same thing. It can spread a little bit more, in this direction, just by the mere presence of the location of a lesion as well. So let's get into respiratory diseases and periodontitis. So this is another pathway that we're going to be talking about, in addition to the local periodontal connection and the leakage of the bacteria and IL-6. We have also a relationship between periodontal disease and respiratory diseases. So this has been also a strong association, very robust association, in fact. Chronic obstructive pulmonary disease, so COPD, has been shown to have higher prevalence in periodontitis patients. These patients have fewer teeth, they have more inflammation, and something that they have noticed is that when you do a SRP on these patients, there is an improvement with their COPD. And the same thing that goes for pneumonia. So when it comes to pneumonia and periodontal disease, there's a significant association as well. And pneumonia and poor oral hygiene, the way they're connected is when you do it, for example, a scaling and root planing or cleaning, and these are randomized control studies, you see that the actual respiratory disease, the pneumonia, can get better and decrease in severity. And so the take-home point is here, in hospitalized patients, we're seeing intense dental therapy does help prevent respiratory infections. Now, I would like to take this a step further in the future, and I believe one of my missions is going to be to educate doctors and hospitals on how to really assess gum disease and how to look for it, possibly get them some probes so they can diagnose in hospitals and really nursing homes even, because mouths don't really get checked too much. People that have bleeding on probing, you know, their gums can be bleeding for years and no one's even diagnosing it. They don't have x-rays, for example, to check, you know, periapical x-rays, at least in hospitals, to see bone loss and these infections. So just that concept, I think, could change the way healthcare moves forward as far as inflammatory diseases, because we can get a significant reduction. And that will be one of my missions moving forward. And I'm open to any suggestions and collaborations as well on that. So there's also a correlation and association between actual lung function and periodontitis. People that have periodontitis have been shown to have a decrease in lung volume, airflow limitations. All of this is, again, corresponding with what's going on with COVID. So very important for our patients to know all of this. They need to be educated on every single one of these. Asthma as well, but asthma is not as strong of an association because there could be other factors such as an inhaler that patients use could be drying up their mouth. So there's some other factors in this, but that aren't as strong of a relationship as the ones that we have just spoken about. So in summary, respiratory diseases and periodontitis, huge association. They affect COPD, pneumonia, and lung function, respiratory lung volume, gas exchange through IL-6, and could possibly lead to severe COVID. Okay. Moving on to IL-6 viral infections and COVID-19. So this disease, it could be with us for a very long time. So we have to be prepared to know everything about it and to do whatever we can to keep it at a minimum and background noise moving forward. Of the people that get this disease, since 5% of them are going on a ventilator, and of those 5%, only 20 to 30% of them are surviving, this is a big deal. And the whole goal should be how to prevent getting on a ventilator. That's the discussion, the main topic of every conversation, and from there we move backwards, because that's how people die. It's a respiratory disease, you lose the ability to breathe, and you go on a ventilator, and from there it's very difficult to come back. And so let's talk about that a little bit, because it's very important. So something to keep in mind is that these ACE receptors that we're talking about, that the virus attaches to, they're not just found in our respiratory tracts, but they're also found throughout the body, in our kidney, in our liver, in our GI tract. So that could be a possible reason why people get some aches in other places of their body. But even more important, these ACE receptors, they're located right where the oxygen carbon dioxide exchange is in the lining of the lungs, in the epithelium of the lungs. So it's really important to keep that in mind. I want to talk about the cytokine storm. And often when I talk to patients, I ask them, do you know what a cytokine storm is? Because that's the mechanism of pretty much how people are dying. And I'm surprised that not too many people know what it is. So I think it's a good idea to explain to your patients what the mechanism of death is with COVID. And how I like to kind of explain it is, I use the intruder, the soldiers, the response, the ringing the bells, you know, how the cells release the IL-6 and they keep sending that signal throughout the body, and all the cells, other cells getting the signal, keep releasing it. Also, it's important to know that IL-6 is just one of the signals, and IL-6 talks to other cells, and they release something called TNF alpha, IFN gamma, IL-1 beta. We have all of these different cytokines, and they're pro-inflammatory. So you have inflammation in many different dimensions in the body. And when they get out of control is when we have this storm. So just to kind of recap, imagine, just give you an analogy, imagine you're fighting someone and all of a sudden you get into a mode where you're almost getting beat and you just start swinging uncontrollably. And so that's what the body does. It's sending the signal uncontrollably, and it's kind of storming and increasing. So now you have this elevation in the bloodstream of these CRP, IL-6, and all of the other, you know, bad, harmful proteins. Which leads me to the most important article that really says everything. And if there's one slide you want to pay attention to, and one concept, is this. And this is what sparked my study and my research, and kind of gave me that motivation to want to learn more, because it's such a strong association that they found. Basically, you have a team of researchers in Germany. They created a very simple study, and what they did was they looked at people who came into the hospital. They drew their blood when they came into the hospital. They checked all of the immune functions. They looked at IL-6, CRP, they looked at everything. And they wanted to see what's going on in the blood. Then they also took their blood at different times while they're in the hospital. Perhaps before being on a ventilator, after being on a ventilator. And they found that when the moment that they get onto a ventilator was basically at a certain point. When IL-6 went over 80 picograms per milliliter, that's when they see that people lose the ability to breathe on their own, and they need a machine to breathe for them. Now that's pretty shocking, because when I saw that, I felt like no one was really talking about that in the medical community, in the dental community. I know that there's this, as a periodontist, I talk about with my patients periosystemic, I talk about heart disease with them. You know, so I was very, you know, my radar is very high for these types of things in general. So when I saw this, I thought it was really important to find out more information. And you can see there's two outliers. And in science, when you see outliers and there's one on each side, you cancel them out. But even if you leave them in there, they showed that there's a 22 times higher chance of being on a ventilator when above that line. Every attempt must be made by medical and dental professionals to keep people below that 80. And again, 22 times is a very strong association. It's over 2,000% stronger. And that's why they're able to use, in the article, they're able to use the word predictor, that IL-6 and CRP together, when elevated at above a certain level, is a predictor for people being on a ventilator. Not associated, not causation, not linked, not connected, but predictor. And in science and in papers, very rarely we're able to say with such certainty of such a statement. Another drug I wanted to bring your attention to is dexamethasone, which has been getting some news lately. Dexamethasone is a steroid. It's anti-inflammatory. It has been shown to decrease IL-6 levels as well. It works in a more systemic pathway, so either through pills or through IV. And they've been giving this mainly for people that are pretty deep into the stage, the severe COVID stage. when they may not be able to even breathe. So they're giving that, and the studies have been showing that it decreases death by 30%. So this is a great weapon, 30% decrease. I think that something that hospitals are doing right now more and more of. One treatment I'm personally very excited about are inhaled steroids through a nebulizer, through basically a gas mask that is an asthma medication like budesonide, and you can breathe in this gas steroid locally. Since COVID is a respiratory disease in the upper, it starts in the upper respiratory, by inhaling and breathing in, it will decrease inflammation locally. Also, you're breathing in it, so it opens up the bronchioles. And what this has been doing is kind of like a firefighter putting out a fire locally. Dexamethasone, when you're giving it systemically, it's when the fire has already jumped over the freeways, down the road, you want to just put out everything. Dexamethasone lowers the immune system as well. So it's a little bit more risky in that sense. Getting to it early is ideal. So getting it while it's still here and it hasn't reached the lungs. Now there's countries that have been putting this in protocol in place. Taiwan, for example, and we've seen good results there. We're starting to do it in America a little bit more. There's a lot of research being done on this. Very promising. They're also looking at just asthma inhalers with steroids to open up the bronchial. So this is promising. We're looking at more and more studies. There's a doctor in Texas that has had a video go viral about this. I actually called the hospital that he works at to investigate a little bit further to see the truth in it. And I talked to one of the other doctors there, and he confirmed it. The other doctor said, yeah, every patient that we treated with this has gotten better. So this is very promising, and let's look for some news on that. So to summarize the last couple of slides, we have this cytokine storm, we have inflammation and the sources, we have treatments now that can counter these, and it has been shown that poor plaque control and periodontitis can negatively affect these hospitalized coronavirus patients. So we have inflammatory mediators locally produced. We have IL-6 released in the gums, in the gingiva. We have the immune system activate, which further releases more IL-6 throughout the body, going through the organs, upregulating inflammation everywhere, releasing TNF alpha and all the other ones we talked about. We have also bacteria, actual bacteria going into our bloodstream. And that basically what it does is it causes bacteremia and further systemic inflammation. So a concept that I would like to share with you and for you to share with your patients really is the fact that there's so many bacteria in the mouth, and just on one surface of one dirty tooth with plaque, there's over 100 million bacteria. And that bacteria, once it gets into our bloodstream, it again causes inflammation, but it can also get into our bodies in different ways. So one way it could get aspirated, the secretions of the oropharynx area, you'll see that it can adhere to the respiratory epithelium, release that weapon that we call the LPS, and basically adhere to the receptors in the lungs. Also, we see that enzymes are secreted as well, and that could alter the lung epithelial and the bacterial surfaces, facilitating the adherence of bacteria. And lastly, we have cytokines, which can modulate bacterial adhesion of pathogens to the pulmonary epithelium. So really 3 ways that we're seeing this happen. Another possible mechanism that's been proposed is the relationship between us swallowing actual bacteria into the gut and creating a gut imbalance. And what that does is when we swallow bacteria, the bacteria, for example, like P. gingivalis, it can survive through the acidity of the stomach and release something called LPS, which is the weapon that they have, which then causes an endotoxemia, leading to systemic inflammation. Now, we know that the two dirtiest parts of the body are the mouth and the gut. And we've been hearing on the news and through social media about the relationship between the gut and our overall health. So if we are causing an imbalance in bacteria in the gut, and it's starting by the swallowing, then we have an opportunity as dentists and dental hygienists in the dental community to really affect the health of the mouth, prevent that bacteria from getting into the bloodstream through the actual swallowing, and make a huge difference in that pathway as well. Another pathway that we need to talk about is endothelial dysfunction. Now, remember, endothelial cells are the cells that are lining our blood vessels. This is the pathway that has been linked to atherosclerosis and heart attacks and strokes. What happens is the bacteria that flows through, it causes that inflammation, releases those cells that break down and play with and mess with really those cells that cause the blood vessels to dilate, and that's through a nitric acid mechanism. When that blood vessel is not able to dilate, blood and other cells that we have that are needed to go flow and go fight and help our body can't flow as well. And so this is, again, very important because this is the link to heart attacks, strokes, and other things, but also to COVID, because that blood is needed to go as a kind of like a freeway through the body. It needs to be open. We can't have any of these lanes of the freeway clogged up right now. We need everything open. We need our body to be able to respond. And if you think about it, diabetes is also clogs up one of those lanes. If someone smokes, they clog up one of the lanes in the freeway of the body to go respond. Hypertension. So that's why these are all factors of people that aren't doing so well with COVID, because it's all about blood flow. It's all about being able to provide your immune system cells to go fight. It's all about being able to provide oxygen to the lungs at this time. So here's a summary slide where it might not be a bad idea to print this, laminate this, and actually show the patients what is going on, because you can see that there's direct pathways to COVID, indirect pathways to COVID. You can get aspirated, you can have bacteremia, you can have that systemic inflammation or the cytokine storm. You can have IL-6 directly going into the lungs and not allowing the oxygen gas exchange. You can talk about endothelial dysfunction that we just talked about with the blood vessels. We can talk about swallowing with the gut imbalance and gut dysbiosis, changing the effect of the lungs. And all of that combined together will cause a huge difference in people's lungs at this time. I would like to talk about some periodontal treatments in COVID as well. But before I talk about the actual treatments, again, let's talk about how important it is to what we are doing in our everyday lives. Now, we are seeing people who have been in a pandemic, staying away from the offices. They haven't maybe had a cleaning for a while. You talk to a patient, you ask them, when was your last cleaning? If they're a new patient, and when you don't know, they'll say, I don't know, maybe it was about a year ago, and probe a little bit further and kind of check and see, and they say, well, you know what, it's actually probably been closer to like 2 or 3 years. So we've seen dirtier mouths at this time, and we know that there's a 22 times higher chance of people getting on a respirator that have this higher very elevated IL-6 level. So how, as dentists, what can we do to lower inflammation? What are we able to do to help them with what we do in our everyday practice? So as oral health professionals, we have power at this time, and this is our power. We're able to clean and do SRPs and osseous surgery and do exams and notify them and basically be able to minimize two things. The IL-6 locally. There's a study that's very important. Actually, this is a study that was done by the co-author's mentor, and it shows that when you do a scaling and root planing on a patient that has periodontal disease or chronic periodontitis, you'll notice on average the IL-6 level will go from 3.3 to 0.25 picograms per milliliter. In that study, they showed that the IL-6 level in the range was about 0.25 to 41 picograms per milliliter. So you do have some people that come in with pretty high levels, and we are able to, and this is just with an SRP, scaling root planing. Now imagine they need some osseous surgery. Imagine they need a tooth that has a lesion, a root canal that's gone bad. So we are able to lower this inflammation systemically. And when you look at the CRP levels, C-reactive protein, with just the scaling and root planing, we're able to decrease it by greater than 50% in their blood levels. And this is so important. I remember one of my friends actually recently, he lost his hearing for a couple of weeks completely. And they checked his blood. It was a few weeks of the doctors not knowing what he needed, and very scary for him. And he was in the hospital. I was one of the first people when I found out. I went to the hospital and I brought my probe and my sterilized instruments and my mask and my light, and I looked in his mouth and I checked his gums because he had told me, and when I interviewed him, I asked him, so what's going on? They said all they know is my CRP levels are really high. So I looked in his mouth, and his last cleaning was quite a while back. And I said, you know what? Well, if that's all they know, why not, let's look at your gums. I checked, and he had some 5mm pockets, multiple areas. He had a lot of bleeding on probing. So right then and there, I did cleaning for him. And I felt like, it was a friend helping a friend, but I had to do whatever I could and what I knew, and use the science that I knew. And then I came across this article a little bit later, and I realized that intuition was correct, that we need to be more proactive in helping, especially hospitalized patients that may have these inflammatory diseases. So the future, I believe, is bright for hospital dentistry, for periodontics, for referrals from hospitals and medical clinics to dental offices, for hygienists to be speaking about this, being able to do more SRPs if needed. I believe that we also need to have this moment to be able to, that one patient, for example, that you saw that you were doing for years, not so aggressive of a cleaning because they're so sensitive and they're scared to get touched and they don't want any pain. This might be a moment where you can say, this particular area, we haven't really went in so deep in years. Is it okay if I put some numbing gel here? Or maybe is it okay if I do an injection or two in your mouth on the deeper areas and just go a little bit deeper, for example, in between number 14 and 15 or distal of number 2. Because remember, you have a furcation on the distal of the upper second molars that need to be addressed on many patients. When I'm doing osseous surgery, I see that there's many times furcation happening in these areas. So they need to be looked at. Our probes need to be not bent. They need to be newer probes. They need to be angled correctly. They need to go a little bit deeper to actually get to the bottom of where we're going, especially if it's in between the number 14, 15, number 19, and number 18 areas. So very important right now to be a little bit more proactive and push the limit and tell the patient, you know what, I want to just make sure you have no inflammation. This is why I'm trying to help you out. I would like to now talk about something I alluded to earlier, and that's IL-6 genetic testing. So talking about this test, again, gives us whether we're high, medium, or low, we're able to make better decisions. And just to talk a little bit about some of the unpublished data from Oral DNA Lab of the patients that they sent, the dentists have sent their samples to, the 45% of them show a high risk, 41% show medium or intermediate risk, and 13.8% show a low risk. So this is a skewed population because these are a lot of time people that already have issues. But we've seen other studies by Trilovato that talks about GG being 71% of periodontitis patients and 50% of moderate periodontitis patients. So if people know genetically what their IL-6 susceptibility risk is, they can better make decisions on if they need to get cleanings more often, if they need to, with COVID, be a little bit more cautious in leaving their homes and wearing masks. If someone is a low risk, perhaps they may not be in as much of a risk. So this is how a lab report will look like when you get it back from Oral DNA after taking a bacterial sampling test. They will let you know which bacteria are in the mouth. You will know as far as periodontal pathogens. There's also one that you can get for more of like a karyogenic test. They'll tell you which strep is in there, how much of it is in there. And you can see in the second box that shows that there's a high IL-6 level with this particular patient. And also you can see which of these bacteria are affecting which part of the body. So this is really important because if already someone has arthritis, and we know, for example, that Fusobacterium nucleatum is high in their mouth and they have this arthritis, very important for them to know that possibly reducing the bacteria and getting a deep cleaning or osseous surgery could lower their risk of this systemic issue or improve it possibly. But we've seen periodontal disease linked to multiple cancers. Usually it's some of the worst cancers like pancreatic cancer. We've seen it be linked to Alzheimer's. We've seen it be linked to erectile dysfunction in men and affect pregnancies in women. So it really affects all sorts of people. There's also, in particular with women, there's a bacteria called Prevotella intermedia that crosses the placenta. So if someone is about to get pregnant or during maybe the second trimester, it's very good to have them come in and make sure that their gums are clean. And especially since during pregnancy, we have some hormonal changes, actually gums can be a little bit more out of control during pregnancy. And again, this is a sample of what the report would look like when it comes back, and giving some more information on the level of IL-6 and how it affects the body. All right. So let's talk about solutions, because we are problem solvers and we need to provide solutions at this time. We're just as important as any other doctor, and I will show you what are some solutions that we should be explaining to our patients, steps that they should be making during this time. So in terms of solution, the best solution is prevention first and foremost. To prevent, we have to think about what is our role as dental healthcare providers. Now, when I applied to my residency, I applied to I went to USC, but I applied also to UCLA. And one of the interviewers, Dr. Henry Takai, he had me in an interview and he basically asked me one question. And he asked me, he said, what is a periodontist? If you could put one word that describes what a periodontist is, what one word would that be? And I must have been a good 5 minutes of throwing out words, every word in the dictionary, synonyms. And he said, no, no, no. I got close to it, but he wanted to hear the word. And finally, I said, okay, so I give up. What is that word? And he said, teacher. Periodontist is a teacher. That might be why I didn't get into UCLA, but that's an important thing to understand, because we need to be teachers. And some people might say, well, it's too much information. Oh, I don't have the time to explain it. Or I feel like I'm scaring them. But in fact, not educating them and not talking about how the mouth is connected to the body is a disservice to your patients. You are harming them by not telling them. And as our oath that we took is to do no harm. So I feel and I believe that to do no harm is to educate and to teach our patients about this. So how do we do that? How do we teach them? We need to screen them. We need to test them. We need to do a full mouth probing. We need to show them in the mirror. We need to in the mouth and show them in an x-ray, show them what a diseased bone looks like, what a normal bone looks like, compare. They need to really see it to believe it sometimes. We need to explain how to keep their mouths clean at home when they're not there. Brushing twice a day, flossing twice a day. How are they flossing? Are they flossing properly? Are they using those little sticks that you go up and down, those type of floss? Well, that's not really wrapping around each area like you're shining a shoe. You need to go in and wrap around like you're shining a shoe in a C-shaped manner to really get underneath. Now, some patients will say, well, I use a water flosser. Well, that's not a real floss. It's the analogy of that is tell them it's basically like you have a really dirty car that hasn't gotten a car wash for months, and you get a strong hose and you splash and hose down the car. You're still going to have a dirty film on top. It'll just be a little bit less dirty, but it's still going to be pretty bad. You need to actually physically get a towel with some soap and scrub. And so that's what the toothbrush and the floss does. 2 minutes for the toothbrush, 30 minutes per area. I like electric toothbrushes, especially for the elderly, since it's hard for them to brush. They don't need to brush so hard. They need to brush for a longer period of time. Also, mouthwashes. Povidone iodine or betadine. Also iodine. Some people are allergic to it, so you need to ask and make sure they're not allergic to it. Or if they have thyroid issues, you need to be careful and ask them because they could interact with their thyroid. But in general, if they're allergic to shellfish, you want to stay away from this. But this is really good because studies have shown with COVID that povidone iodine will decrease and kill completely the COVID virus in the mouth and in the throat. And since that's a reservoir, that's a great thing for people to be doing. Also, betadine, people are also using it as a nasal spray for prevention or on the first symptom of getting COVID. Also, we're talking about scaling and root planings. Again, this is not a time to be just only doing prophies necessarily. Go a little bit deeper if you can. Again, you don't want to traumatize and break the long junctional epithelium of the connection between the tooth, but you want to really get in at the point where it stops and then clean it really well. You don't want to harm them and create more of an opening. So that's the art. That's why we're the healthcare professional that we are, because there's an art of knowing when to go deep and when not to. Usually in the front, we don't have as deep of the pockets and we don't have multiple roots, so we don't need to usually go as deep in the front because the pockets aren't as bad on the general population that we're seeing. Also, this is a great time right now to refer to a periodontist if you think that the bacteria might have gone into the bone, or if there's a pocket 5 millimeters or greater. Very important. They'll appreciate you. They may not know what a periodontist is. Educate them and say, this is a person who will be able to go deeper than I am able to. And for example, we can get into pockets 5 millimeters or greater, because the research shows that greater than 4.5 millimeters deep, hygienist is not predictably able to clean the tartar. And these are on studies where they've done, half a mouth one way, half a mouth another way. They extracted the tooth, they put it in a microscope, and they show that 4.5 millimeters is the line. So how do we get deeper? We have to numb the gum, perhaps. We have to maybe gently lift the gum back, clean up underneath, and you have to see it sometimes to clean it all, because it's very hard to clean everything if you can't see and you're only going based off of feel. And the analogy I like to give patients is, it's like a swimming pool that is 6 feet deep, and you only have this 4.5-foot stick. You may get some of the sides of the swimming pool, but you're not getting the bottom of it. So we need to go a little bit deeper, perhaps. So let's have the periodontist take a look at it and see, check it. Better safe than sorry right now. The next concept we're going to be talking about is possibly doing the blood test and checking IL-6 levels. So if they already have, for example, diabetes and they have arthritis, so maybe these types of people, we want to check their IL-6 and have their doctor take a blood test and find out where they're at. Again, they'll appreciate it. Many people aren't seeing their doctors right now. Many people are at home. They're afraid to go to the doctor. Some are afraid to even go to the dentist, where ADA came out and said it's safe. So we are and showed a good amount of data showing that very safe, actually, in dental offices right now. So patients need to get that message. We need to get this message out to the patients. And really, we need to send emails. I created a template for an email that I want to have available for you, that you can send to your patients explaining, and you can put the article, which is right now on mouthcovid.com, earlier ahead of publication in September, October, but they will be able to link to it, read the article perhaps if they want. They can learn more about it, and so that's really important and key. We talked about the IL-6 testing, the genetic testing with any lab, but oral DNA lab is very reliable, and I've used them and they've been great. Teledentistry is actually huge right now, and only going to get bigger, because sometimes patients just have a question. They might have an emergency. They may not be able to come into a dental office because they're in a wheelchair. They may live far away from a dental office. We may need to create a mobile dentistry. We already have mobile dentists, but we need to, offices in the future could have a hygienist that will go out to their patients. And I know there's companies that are working on that. And I actually have been working on teledentistry myself, and been part of it for the past, actually before the pandemic, about 1.5 years ago, with a company called Dentulu, and really creating innovative and using technology, innovative ideas to reach out to dentists, creating an app for dental offices so they can communicate with their patients, fill in the chair last minute, and some really smart ideas that will be coming out soon in teledentistry, and other companies too. Mobile cameras, patients could be, sending their images straight from their home on very, inexpensive cameras that are linked to only your office. So very exciting times in that aspect. So moving on to more solutions, we have also diet, which is really important and not talked about as much, but diet is a great way to decrease inflammation in the body. And by increasing the amount of anti-inflammatory foods, decreasing the inflammatory foods, and this can be more of a plant-based approach has been shown to be more anti-inflammatory. IL-6 in particular has in studies been shown to increase with a sugar, more of a sugar, processed sugar diet, and also processed carbs diet. So we want to decrease that during this time and really forever. In the past year myself, I have decreased the amount of sugar I had. I lost a little weight, and you know, you just feel better. And so that I talk about that with my patients. We're not just dentists. I talk about vitamins with them. I want to know what they say. Oh, what vitamins? I'm taking this vitamin. I'll say, you know, right now it's very important to be also taking vitamin D3, and you want to be taking a lot of it. I recommend 5,000 milligrams. I recommend 2,000 milligrams of vitamin C a day. I recommend 50 milligrams of zinc per day. I recommend turmeric. It's a very potent anti-inflammatory. So that is where my approach comes. And they, so far from what I've seen, they really appreciate it. They say, hey, doc, could you write that down for me again? Tell me, okay, what was that you said? You know, so we're taking their blood pressure when they're coming in. We're talking about their diet. We're talking about their gut. We're talking about how to decrease inflammation. And that's the key. If you were to summarize this whole conversation, it's how do we decrease inflammation in the body? It's not, and we're, you know, as dental professionals, of course, we just deal with teeth, but it's okay to talk about everything because we may be the only health professional they've seen this year, and they will appreciate it and look at us in a different light. They will value us more. Everything is all about value. The more value you create for your patients, the more, in their eye, your value is higher, and they'll appreciate you. They'll talk about you with their friends, and your office will be more busier, in my opinion, moving forward. I think it's really important for everyone to read the actual article, as it is an in-depth analysis and the most comprehensive study on this topic to date. The more you delve into it, you'll see it corresponds to basically what we spoke about, but when you read it, it will kind of stay with you a little bit more. This is kind of like the audio book, and that's more of like the book. So keep it, print it, and read it. And so let's talk about some of the points with that. And that article could be, again, found on mouthcovid.com. So our study finds a definitive link between COVID-19 complications and chronic gum disease. Gum disease can make lung disease worse. We know that already from literature. Now, inflammation in the gums can be silent and contribute to the body's overall inflammation. Bacteria in the gums, they can travel throughout the body, spread harmful inflammatory proteins, such as IL-6 and CRP. And when that IL-6 is elevated above a certain amount, 80 picograms per milliliter, that's when our body is not able to breathe on its own. Our lungs fail on us. And also, we from there, it can go into multiple organ failure. And this is shown to be 22 times higher chance of respiratory complications and being on a ventilator. So that's a key point to drive home. Next, COVID-19 is more severe in the presence of inflammation in general. Poor plaque control can negatively affect the lungs, especially in hospitalized patients, and treating the gums of these hospitalized patients can make the lung function better. And we have direct relationships between the mouth. We have indirect relationships between the mouth and the lungs and COVID. So I really hope we have shown this and really convinced everyone that this is real, this is happening, This has been validated. This has been validated by a peer-reviewed journal. One of my mentors on this is one of the past presidents of the AAP, the American Academy of Periodontology, Dr. Joan Otomo-Korgo, who has been really amazing and with giving good ideas, and so this is it's been validated. Dr. David Karate, of the president of the California Society of Periodontists, has read this and has been really give really high regards to this article. So we are now at a point where we need to explain this to dentists, hygienists, to our dental offices, to our community. I'm trying to get out there and talk about this with patients to the public, so we can get people to come into the dental offices, and the risks are far less than the rewards in regards to coming to a dental office. People need to come in right now, and they will benefit. Their mouths are dirty. They need to come in, and they need to decrease the inflammation in their body. Here's another slide that shows the conclusions, but I really want to get at something important across here, that we don't know how long COVID is going to stay with us. This could be like a flu once a year. We don't know about the vaccine yet. There's a lot of unknowns. We're still in the middle of it, learning more. And right now is the time to be proactive, to learn more about it, to explain to our patients what we do know and what we learn. And you never know what we could learn from each other as far as dentist to dentist, even from our patients. And this discussion that we're having here is, I hope, a fruitful one for you. And I look forward to taking some questions, and I'm available through email as well. And if you have any ideas, collaborating, I'm always open to. As Dr. John Laughlin put it, we are taught to analyze body systems and parts separately and to change one area at a time. Such approach often ignores the interconnectedness of the systems in the human body. And I think that's brilliantly put. We go to dental school, we learn about the mouth, and we take a few classes on physiology and pharmacology, and then the medical doctors, they go to medical school and they learn about everything. They brush up a little bit about here, but surprised to know that they don't really know as much about the teeth and the gums. And we need to bring this together. We need to make a middle ground. We need to collaborate, educate each other. Somehow in our healthcare, there's been this lack of connectedness between these two branches that hopefully moving forward, we can bring together more and be an inspiration for future generations to build upon and really help keep our populations, our patients safer and healthier. I would like to take the time to thank you for your attention and this really important matter. Now let's go save some lives. I could be reached at my email, smolayem@gmail.com. And for further information about the article, if you'd like to view it, it's on mouthcovid.com ahead of publication. So thank you so much.